don't wait until it's a flow limiting plaque. And we would say that as well. That's why we don't recommend. I mean, people come to us and they've waited until their cardiologist, and their cardiologist has waited until he or she is saying, you've only got 5% flow left. You had danger for heart attack years ago. And that's what these guys are acknowledging. You had danger of heart attack long before you had impact on blood flow. Jesus, Jeannie, Heather, and I are all on our way to the event in Dallas right now. So we pre-recorded a lot of the show. Hopefully by the time my plane lands, or by the time we finish this video, the pre-recorded part, my plane will have landed and I'll be able to answer some live questions as we usually do. If not, we'll be back again next week. This is going to be one of those shows that's got a little bit of clickbait component to it, or at least it should be interesting to a lot of folks that have heard our content before, because we've said multiple times, stents and then even bypass have been proven not to prevent heart attack. Well, there's a new study out that claims to be accomplishing that. We looked at it, we've analyzed it. They do make a little bit of a case for that, more than a little bit of a case. But it gets into the details. It has to do with things like new procedures, which most interventional cardiologists don't do. Things like IVUS, intravascular ultrasound, OCT, optical coherence tomography. We'll describe those and help you understand a little bit more about what those are. It even gets into some things like absolute versus relative risk. You remember, I've gone toe-to-toe with several content creators like David Diamond and others, where they would say, you know what, I'm not going to take statins because the 50% improvement is a relative risk, not an absolute. And I've said, well, I get that. Don't argue with that at all. But a lot of folks will take that relative risk. I think I'm going to end up on the other side of that argument, that debate, in terms of relative risk versus absolute risk, at least in terms of IVUS or OCT driven vulnerable plaque and stents for that. Now, there's another issue here, and I just mentioned it, vulnerable plaque. If you go back and look at some of our old videos, I've made a couple of videos in the past responding to this thing of, quote, vulnerable plaque. And what I said was, there's no such thing as a vulnerable plaque. Well, I did clarify then, and I think I need to clarify anytime I say that. Yes, there are plenty of vulnerable plaques, but here's the thing, and here's what this article is about. Making an assumption that there is one vulnerable plaque, you can find that vulnerable plaque, you can stent that vulnerable plaque, and then save someone's life. Now, it is true that if you're doing a stent when somebody's actively having a heart attack, you do save their life. You can sometimes find that plaque and sometimes save that life. So is it possible to move forward in time a little bit using some of the technologies that IVUS and OCT? I'm tempted to say new technologies. They're not really that new. IVUS has been around at least 12 years, actually longer. It's taking a catheter and looking up inside the artery itself to do an ultrasound, rather than doing an ultrasound from outside. It's done in the cardiac cath lab. And again, I'm getting ahead of myself. I'm going into some details on that we'll cover a little bit later in the video. Back to the question about vulnerable plaque. So here's one of the places where I do think that I am going to have to eat some crow to acknowledge maybe I was wrong. They're making a good case that using these technologies, they may be able to find that one vulnerable plaque that put the patient at risk. And when you're at that point using relative risk, there may be a case for it. So let's go deeper into that. But before we do, let's go back to my position on absolute risk versus relative risk. So here's what that means in this case. In this case, the question is, do you really want to be dependent on this to save your life? Do you, aren't there better methods, much clearer methods, things like controlling your diet, making sure that you know whether or not you have metabolic disease? If you look at these authors, they're just like what you see with 3/4 of the primary care, cardiology, internal medicine physicians. They obviously don't know how to diagnose metabolic disease. So they have taken as the truth the small amount of metabolic disease that was diagnosed among the patients that were participating in this study, and they have not questioned the ones that didn't. As you'll see in there were a lot of people that had metabolic disease that they just did not bother to diagnose. So after having created a whole bunch of questions about this, I think maybe it's time for me to turn it over to you, Jesus, and let you answer some of them.
Well, let me tell you one thing, Dr. Burr. I think you're using a sledgehammer to crack a nut. Just say you were wrong.
I knew you'd say something like that.
Well, no, and I mean,
you can't wait to say something like that, can you?
To your point, I'm really excited about this article. I can tell you that, because finally, in 2024, we see more research and more research being concerned about the type of plaque and not just the size of plaque. So they're always like, size is it all. And if you go ahead and get a CT angiogram or have any of these tests, they will tell you, oh, it's blocking X amount of % of your blood flow. Therefore, that's why it is dangerous. And it can cause chest pain. It can cause angina if there's too much blockage. But this article is actually now asking the question and saying, well, what about if this plaque has more risk to rupture than the other plaque? And to their credit, they're using what I will call a gold standard to identify that, which is the IVUs and the OCT technology that you described on the intro. Unfortunately, that technology is not available easily. It's either expensive, or people are not necessarily trained, or it's used specifically for research purposes, like in this case.
Well, anyhow, I have to. Yeah, go ahead. Let me interrupt. I have to interrupt and make this point while I'm thinking about it. When you go back and you look at the science, this is not the first study that indicated that A, they could find vulnerable plaque using IVUS, and B, that they could have more of a positive impact. So given that, why do you think nobody's doing IVUS?
I think it's just too expensive and hard to do. It's easier to do a CT angiogram.
And I think it's not even quite so much an issue of expensive, because it adds, what, $1,500 to an angiogram? You take somebody to the cath lab. It's not that it's adding that much. It's that physicians don't want to learn it.
Well, I mean, I have no experience specifically on that testing method. I can tell you that I have seen it on plenty of research, and we have covered some of that when we said, oh, what's the difference between calcification in plaques and how do you measure that? And in this article, I'm really excited about that, because they're saying not all calcification is the same. So
right.
You go out there and get you go there and get a calcium score. Yeah, and they say a higher calcium score is higher risk. And they're saying, wait a minute. It depends on the cap of the plaque. Is it thin or is it thick? If it's thick, maybe that's not going to rupture that easily. But if it's a thin cap, that's when you're in trouble. That's the one that is going to rupture and create a clot, and then you will have a heart attack. But yeah, let's go ahead and see how this team of researchers just basically said Dr. Brewer is wrong.
There you go. You can't. How many times you gonna say it? You can't help but enjoy it, can you?
Well, it's not about you being wrong. It's about being consistent and saying what we're clickbaiting people with. So it's not actually clickbait. We're telling the truth. But also, as you said, there are caveats, of course. It's not that simple.
Yeah, this is going to turn out like Thomas DeLauer does a lot of those clickbait titles where he said, "Oh, this fasting guru says he or she no longer fasts," and you listen to it, and they're fasting. They're just not fasting all day every day. Yeah. Or this keto content creator, the king of keto, is no longer doing keto, and that's not what the king of keto said. He's just not doing as much. And this carnivore is no longer doing carnivore. That's not what he said. So unfortunately, we may have a little bit of that going on here, that I'm still not giving up my lifestyle and metabolic health for this.
Yeah. So the short answer was Dr. Brewer wrong. Yes, but let's talk about the yes, and then we're going to talk about the but.
Yeah.
The BUT, one T only, please. let's keep it all friendly. So let's see the summary. Let's see the abstract. So you have the overall picture, and then we're gonna go down and to see those details. I highlighted a bunch of text, so let's see how much we can cover today. I'm still trying to keep it under an hour. And if I'm not able to go into the Q&A at the end, Dr. Brew will be free to answer any question he wants. So
there we go.
You are free today.
Hopefully I can make it there for those questions. I'm dependent on an airline schedule though. So if the flight's late, we'll have to do it the following week.
Yeah, and I'll be on the road, but I'm gonna try to catch up too. So right from the get-go, I like this background part of this article. So they acknowledge that heart attacks and sudden cardiac death is caused by rupture and thrombosis creating a clot of lipid-rich atherosclerotic coronary plaque, known as vulnerable plaque. We also call that soft plaque.
Mm-hmm.
Many of which are non-flow limiting. So that's interesting because they're saying, yeah, we understand that you don't necessarily have to have a big plaque blocking your blood flow to have risk.
Mm-hmm.
So that's really good.
That is a couple of very positive things, which you don't see very often in this kind of science.
Yep. And they're acknowledging also the safety and effectiveness of preventing therapy with the stents, percutaneous coronary intervention, for soft plaque is unknown. And still, they'll still do it, of course, especially if you have blockage. But if you don't have significant blockage, and if you do have soft plaque, they don't know if stents are actually going to prevent heart attacks or not.
Well, I would argue at that point. I would say that it isn't that it's unknown. It's that it's been looked at before multiple times, and it's not been found to be effective.
So they're closing their eyes and saying, we don't know.
Yeah, they're closing their eyes. I mean, this was done very recently, and the Orbita trial, the Courage trial, the ischemia trials have all been there. They've been there for a long time, for years, and they've shown it isn't that we don't know, it's that they don't work.
Well, I think the caveat for that is that in those studies they did not actively look for soft plaque, though.
Okay, I think that's a valid point.
So
so they're splitting a definition, or I would say splitting a hair here, saying, well, in those trials where it showed not to be effective, it wasn't clear that those were soft, vulnerable plaque. Is that your point?
It was just plaque. Yeah,
it was just plaque. Okay, I think that's a valid point.
Yeah, 2 out of 2. I'm on a roll.
You're smoking it.
Well, that's 2 for all the 100 times I've been wrong. So this study is called PREVENT study, and it was performed in multiple centers in South Korea, Japan, Taiwan, and New Zealand. They enrolled patients 18 years and older with non-flow limiting plaque. That is plaque that even though there was plaque in there, 80% of the blood flow remained within the vessel. So they were not actually having angina symptoms or anything like that because of the blockage on the specific arteries, the ones they measure for this purpose.
Which I would compliment them for. I mean, and you've already said that. They're saying, look, don't wait until it's a flow limiting plaque. And we would say that as well. That's why we don't recommend. I mean, people come to us with, and they've waited until their cardiologist, and their cardiologist has waited until he or she is saying, you've only got 5% flow left. Well, you had danger for heart attack years ago. And that's what these guys are acknowledging. You had danger of heart attack long before you had impact on blood flow.
Yep. And they are looking the cause of the danger. Well, not the cause, the effect of that danger, which is the vulnerable plaque. Because it's still, they're a little far off on the cause of that soft plaque. But they're looking for soft plaque, which is good. And they randomize them 1-to-1. So one group for each intervention, one received the stent, plus what they call optical medical therapy. We'll discuss a little bit more about that later, versus no stent and optical medical therapy alone. And they said they stratified based on multiple things, including diabetes. And I was really curious about this point, which I did not highlight, the performance of stents in a non-study target vessel. So they're measuring stents placed on plaques that are actually obstructing the flow, but also the effect of a stent on a plaque that is not obstructing the flow.
So what they're saying is, if they have a diagnosis of diabetes, we know they have much greater risk. And so we're looking for people that have that diagnosis versus people that don't. And again, one of our counters to that is, 10% of the people that actually have metabolic disease are carrying a diagnosis of diabetes. The majority are not, because it hasn't been picked up yet. They're also saying, look, if you've already had a stent, the same thing as if you had carrying a diagnosis of diabetes, you're at much greater risk. So we're going in now and looking for a non-flow obstructing plaque, looking to see, do we think using IVUS that it is a vulnerable plaque? And if so, we're going to stent it and see what happens. That's basically the study.
That's right. And they followed these people for over 2 years at least, because they have follow-ups until 7 years.
Mm-hmm.
So it's until the last person enrolled accomplished the 2 years, which at the moment where they ended the study. And they were measuring how many people died from cardiac causes, how many people had heart attacks, how many people had revascularization or hospitalization because of angina.
And that's pretty standard for the kind of endpoint events that you use. They used Kaplan-Meier, which is a life table, which is, for those that remember the Honda study used Kaplan-Meier. It's basically, it's a straight line until somebody has an event, and then the straight line drops down until somebody else has an event, and then it drops down again. And so you measure the two groups by seeing how quickly the lines drop.
Yep.
And you'll see that in some of the images as we go through this.
Then what they did, they followed this. Well, they gather information from people for 6 years. They assessed 5,600 people, included 1,600, and they randomized 800 to a stent, 800 to optical medical therapy. They had mostly men, which is a limitation from their study, but what they got. And they completed the assessment for 97%, which is a really good number. They didn't have many dropouts. So that's really good. And these are kind of the main results. At 2 years, 0.4% of patients on the stent group versus 3.4% of patients in the medical therapy group, those who did not receive the stent, had one of those primary endpoints that we discussed: cardiac death, heart attack, revascularization, or hospitalization because of angina. So basically, those problems were more prevalent on those who did not get the stent, 3.4% versus 0.4%. Do you want to translate, Dr. Burr? I think I butchered it.
Well, yeah, if I'm reading it correctly, I think that's adding a little bit of power to the study by saying, look, we randomized. There's some evidence that, one of the things you worry about is, was the randomization effective, or did you get higher risk people into the study group, or vice versa? And it looks like you may have gotten higher risk into the placebo group, meaning if the study intervention, in other words, the stenting here, does show fewer endpoints, fewer events, it's even that makes it a little bit more powerful that maybe that those fewer events were significant. I hope that helped.
Well, kind of.
In other words, I think it made it a little, if anything, that finding that the placebo group, or not, it's not placebo, but that the control group, the control group had a little bit more of these extra risk factors, would indicate it adds to the power of the study, when at the end you see that the intervention actually appeared to help.
Well, to their credit, even though this was not a double-blind randomized control trial where even the researchers did not know what the patients were receiving, because it's hard, because these are not pills. This is an intervention.
Right.
Still, I think when we see the baseline characteristics for each group, they're pretty much similar. So I don't think the results are statistically or concerning bias, I don't think that's the case. I think the results are real.
I have to suspect that they are as well. And again, as I've mentioned before, it raises some of the question that if this is what you do all day, every day, why are you not doing IVUS and OCT? I'm going to go back and make another point. Well, I'll leave that point for later.
Yeah, don't forget it.
I will.
And if you go to the details, if you see how many people died, 0.5%, that is 4 people died in the stent group versus 10 people in the control group, 1.3%, which in the numbers, like 4 versus 10 doesn't seem that significant. But when you run that through a statistics, it's significant. Now, how many people had a heart attack after this process? 9 people on the stent group had a heart attack. That's 1.1%, versus 13 people on the control group, which is 1.7%.
So this is where we get, I mentioned early on in the intro that you get into that absolute versus relative risk thing. And if you're one of those 13 people, that's that 4 is a much more significant number. That's the same thing that David Diamond brought up about statins. He's saying, look, if statins have a 50% relative risk reduction, how big a deal is that? If you're starting from 100 and there's 8 people, or I think the numbers he was using was something like, if you're starting from 100 and there's 2 people, you decrease the risk to 1, you're only dropping 1 person out of 100. Now, to me, I took the other side. I said, yep, I deal with the 2 people all the time. And yes, they want to cut their risk in half. But that's a statin. This is going in for a procedure, and it's a little bit different, I think.
Yeah.
And now I have to get back to the comment that I started to make before that I didn't. And that is, I know this sounds very critical of the medical community, and I don't really mean to be as critical as I sound, but it's true. If this really is saving lives, why are the 2 reasons why docs don't do IVUS and OCT? The major 2 reasons listed as: number 1, cost, which may compared to everything else they do, the cost difference is not that big. And number 2, operator what's the word?
Dependent.
Operator dependent, operator choice, operator lack of familiarity with the procedure. In other words, the interventional cardiologist doesn't want to learn IVUS or OCT. And what does that tell you? Either A, they don't think this is working, or B, they don't care. Or C, maybe it's just much of a hassle. So none of those. The fact that it costs too much, again, compared to what the cath lab work that they're doing is not can't be valid looking at it from face value.
Definitely. And if you see the overall results, the conclusions to what they go is they say that in patients with non-flow limiting soft plaque, a preventive stent reduced MACE, major adverse cardiac events, deaths, myocardial infections, hospitalizations, caused by those soft plaques compared with optical medical therapy alone. I think they are right on the side that this is the first large trial to show this. And this is the part I'm concerned about. Consideration not to be more meticulous about where to put the stent. Consideration to expand indications for stents, including non-flow limiting and high-risk vulnerable plaques. So what I think probably is going to happen is that we're going to have more stents without the necessary process of finding that soft plaque first.
Now, to your point, or to clarify that point, we've never said that stents don't help. We've said that stents save lives. But only 10% of stents, when you're having an active heart attack and they are able to remove the clot, yes, it can save your life. 10% or actually less than 10% of stents are done during an active heart attack. And doing a stent for prevention is the standard out there, and it doesn't prevent it. So tell me again, you're worried that we're doing too many stents? We're only doing 10 times too many already.
Well, you're being facetious there, but I'm concerned.
Yes,
they're saying
facetious. I'm sorry.
I'm seeing a paper which will say, well, there's a paper that says that stents prevent heart attacks and leave all the details behind.
And then we should do more.
Yeah,
why not do more?
We're in the right track.
Why not do more?
It's actually helping in people who don't have obstructive blood flow, assuming that it helps some people with obstructed blood flow.
For those of us who think that I'm a curmudgeon and that Jesus is just putting up with me, I'm not the only one. Go to the standards committee for the American Heart Association, the internal medicine standards committees, the cardiology standards committees. They all say the same thing. We are doing way too many caths. We're doing way too many stents. We're doing way too many stress tests. And we're awash in assumptions of flow study and plumbing. And we just should not be doing that.
Yeah. And I don't think that's the main takeaway they're going to get from this study. They're not going to
I think you're right. I think they're going to want to do more.
Yeah. And they're not going to say, let's do less stress test. I don't think they're going to say that.
They're not going to say that either.
Well, and I should have highlighted this before. Look who did the funding. Cardiovascular Research Foundation, Abbott, Johan Corp, CAH, Cordis, Philips, Infrared X, and Nipro Company. I mean, I'm not saying the results are flawed. It seems like the research is well done. I'm just saying all these people had some benefit to gain if the result is.
You mean like selling more instruments?
I mean, I won't be against doing more OCT and more IVUs. I mean, if you can see the soft plaque, why not?
You know, to your point, and I'm covering that in a couple of other videos right now, how I'm saying, you know, some of the food videos, people are saying, oh, if it was funded by industry, you can't do it. And I'm saying, you know, there is no study that's perfect. If you can't deal with imperfection, and clearly funding is one of the major sources of imperfection, then you can't you're not going to get very far, or at least you're going to. Most of us will be dead by the time you take some of the interventions that you should take, especially in the diet area. To that point, I will say, and you've already said it, technically, you look internal to a lot of the assumptions and filters that this study group is bringing to the table. They're right on a lot of stuff, but unfortunately, it's likely to be misinterpreted.
Definitely. And this is overall situation what was before this paper was published. We're gonna go to some of the details and caveats. One of the highlights we already discussed. The added value, yes, is putting stents on soft plaque, but this is the part. This is the key part. Vulnerable plaques identified by intracoronary imaging, and I don't think people are gonna do more intracoronary imaging, at least not in the on the short term. Probably later. Probably we'll see that technology be a little bit more mainstream.
I think it's going to be too convenient for the cardiologists that read that, the interventional guys to read that and say, well, it's still, I'm going to pass over the recommendation to do IVUS or OCT and just say, okay, yep, now we should be thinking about doing stents even when they're non-occlusive.
Yep. And let's go a little bit more on the deepest part of the article. One thing I want to highlight over here is this part. Thin cap fibroatheromas. So we know that plaque that has a thin layer of calcification on the side of the plaque that goes in contact with the blood flow, that's the dangerous part. If you have a calcified plaque with that thick cap, a larger calcification closer to the blood flow, there is a more stable plaque than this one. So they acknowledge this is the dangerous one. There was a single randomized controlled trial studying stents for soft plaque in the past, but this study was not looking for clinical outcomes. So this is kind of a improved version of that past paper.
I wonder. Go ahead.
Well, we should cover that maybe in the past.
I was going to say, I wonder if that's the one that I found.
Probably, very likely.
Yeah, it'd be easy enough to check.
And patients 18-year-old, and we said, with that had plaque, but it still had significant flow reserve. The blood flow was still going around. Those are the ones that they choose. But also patients who had patients who had lesions causing acute coronary syndromes, causing heart attacks. Those people still got stents, which is good. But they're still including people who already had heart attacks on the group. Just so you understand, this is not healthy people. They're including people who already had a heart attack and they already had a stent. But they are measuring the effects also of the stent on the place that did not have the heart attack, if that makes any sense.
Yes. So again, they're taking folks that already have a diagnosis of diabetes, which is, again, it's the top 10% of people with metabolic disease. In addition, they're taking people that already have had an event, in this case, an event, either a heart attack or have had a stent. So yet another group that we know already at very high risk for disease.
And the second part, which is one of the caveats too, but I mean, they're anyway doing stents on people because of the blood flow. But the people they are measuring actually is not that just they have 80% of blood flow preserved. It's people who have at least 50% of blockage. So the people they are measuring is actually people with plaques that are blocking 50%. They are still not including those with less than 50% blockage. So they're waiting for the 50% blockage, but that still have 80% of blood flow preserved, plus the soft plaque criteria.
Now you confused me on that. I thought they were basically taking people that had a stent in the past because of blood flow blockage, and looking at vulnerable plaques that were not blocking flow and capping those.
That's the key part that they leave out of the abstract. So they're saying people who have 80% preserved blood flow, but here's the kicker. Those people still had plaque 50% or more, blocking 50% or more. So I don't know if that makes sense. You can have a plaque that is blocking 50%, but still keep 80% of the blood flow preserved. Does that make
No,
sense?
FFR,
Yeah.
functional reserve.
Yeah.
In other words, beyond the plaque, you can get
Yeah.
that back up to 80%. In other words, they're talking about a place. Yeah. Okay.
So they have they have big plaques still. They have big plaques.
Yeah.
These are big plaques that even though they're blocking 50% of the space, they're not blocking all the blood flow. The blood flow remains to 80%.
Yeah.
So they're still missing people with less than 50% blockage on the size of the plaque.
So one of the things, very few, I think very few people are going to pick up on that. Functional flow reserve is something that has come up with more of the AI-driven technology, where you can see like a very small area of plaque, and then if it's not a long area of obstruction, you can actually get a lot more flow, even though it may obstruct more than 50% of the diameter at that one place. And again, that's something that's coming up a lot more often as you look at AI-driven analysis. And that's what you're talking about.
Yeah, if you want to see it this way, a 50% blockage of the plaque doesn't mean that you're going to have 50% of the blood flow stopped.
Right.
It doesn't mean that, because you can increase the pressure and get more blood flow going through it.
If it's a very thin area of blockage.
Yeah. What I'm saying is they're not including 50% blockage, less than 50% blockage artery.
Yeah.
So, and probably to their point, they're focusing on the blood flow still, which is probably more significant than the plaque size anyway.
Yeah.
And I'm going to skip a little bit on the definition of soft plaque. It's a little bit technical, but basically they're looking for plaques that have at least 4 square millimeters area on what they call plaque burden of 70%, which is just a combined number of how much plaque the patient has. Very low people, we're going to see that further down, were classified as soft plaque because of the thin cap alone, which is a downside, because to measure the thin cap, you will have to do the OCT. And not all of them got OCT. Most of them got IVU, which is just the ultrasound, the IVUS.
Yeah.
Yeah. But anyway,
so,
yeah.
To bring back up to that to 50,000 feet for a more casual listener, bottom line is, as you said earlier, to their credit, they're actually looking for soft plaque. Their version, how they define soft plaque, is a little bit different from the way we do that with CIMT, but they're looking at soft plaque. In addition, they're also not looking so much at plaque that has stopped all the blood, over 50% of blood flow, both of which are standards in the community right now. Only do plaque that's beyond 50% of the blood flow, and everybody, including everybody in prevention, would agree with Princeton prevention that 2/3 of heart attacks occur in people before they get that level of, or 2/3 of people that are having heart attacks don't have that level of blockage. And to our point, you really want to look for soft plaque, not, once you get calcified plaque, as these people are acknowledging, you really don't have the kind of risk that you do with soft plaque.
Definitely.
Now, it got very confusing in terms of their interpretation and how they're describing what is less than 50% plaque. And that's where this functional flow reserve issue became an issue. And then it got very technical and confusing in terms of how they describe soft plaque, which got into the thin fibrous cap. But again, get back up to 50,000 feet, they have done a couple of things that we would agree with in terms of don't look just at flow occluding plaque, and look mostly at soft plaque, not stable plaque.
Definitely. And to their credit, they had a group a clinical events committee, who were the ones who were receiving the results of each people having events, they did not know who received stents versus who got optimal medical therapy, which is a good thing on the assessment part.
Yeah, I was going to say, you said a few minutes ago they really couldn't blind it, and I started to interrupt and say, yes, they can. They just blind the analysis. They don't blind the actual procedure.
Yeah,
which is what you have to do in this kind of study.
Yeah.
You can't blind to the operator what he or she did or did not do.
Yep. Now, the procedure part is interesting, and there's a caveat and a bonnet hole that I don't think we're going to go there, but the procedure itself, they started using bioreabsorbable vascular scaffolds produced by Abbott, but during the testing, those got taken out of the market because there was some research suggesting that those stents were causing increased clots and cardiac risk. So they stopped using those and started using some metallic stents. But most people got the bioreabsorbable stents.
You're right. Don't want to go there.
Yeah. And the downside of those stents was the bioreabsorbable, that they will only last for 2 years. The metallic ones will remain for a longer period of time. And that's a conversation for another topic, but that's what they used. People who received the stent were on to blood thinner therapy, most than the optimal medical therapies. So the ones from the medication lifestyle group did not receive that many blood thinners. And unfortunately, we don't have access to the appendix to see what the optimal medical therapy was. But our guess is basically low-fat diet, high-dose statins, which they say here, and maybe some guidelines regarding exercise.
So low-fat meaning an insulin-stimulating, high-carb diet, right?
Yeah, and we're going to see a table where some people on both groups were treated with injected insulin too because of severe diabetes. No wonder. But anyway, they did a follow-up, and basically what we discussed, the MACE results, the heart attacks, the revascularizations, hospitalizations, and there was some secondary outcomes regarding re-stenosis or developing plaque on a previous stent, bleeding events, a stroke, and other complications. And they had some assumptions that the stent group will do better, even though they had less events than what they predicted at the beginning. And the power of the study and the statistics is really good because they had a good sample. And this part over here, I'm going to jump a little bit on the statistics to make it a little bit simpler. We're going to talk about number necessary to treat later on. And I'm going to go to the table. Probably it's going to be easier to define. Overall, both groups were pretty much similar, which is something that you want on your research, so it's less biased. They did have around 250 patients with what they identified as previous diabetes diagnosis, 244, 246, 16 people with insulin therapy on the stent group, 21% in the control group. But take a look at...
While you're there, let me go back and quote Joseph Kraft. You remember what he said about cardiovascular disease and diabetes?
Oh, he said a lot of things. What are you thinking?
He said, and I think he's true. I mean, he was one of the first guys to really point this out, that those who have cardiovascular disease but don't have diabetes have undiagnosed diabetes. And he's not entirely true, but he's probably 99% true, 98, something like that.
We're going to show you something that will make a point out of that, because I agree with Dr. Brewer. Surprisingly, I agree with Dr. Brewer, right?
As much as you beat up on me. We both agree with Dr. Kraft, Joseph Kraft.
Oh, well, you can put it that way. I agree with Dr. Kraft. No, I agree with Dr. Brewer. Dr. Brewer is my sensei. See here, we're going to see down the line what they're saying is the main cause, and what they have plenty of success with the stents, and that's because they have patients on high statin therapy, decreasing LDL. But if you see the baseline numbers,
it's
really even from baseline, they already have LDL cholesterol on 88. So it's not like these people don't have an average of something else already. This is people who very likely already were on treatment and still had an event, and then they were enrolled into this research paper on this experiment. They had low LDL, HDL too, and see the triglycerides. So the standards will tell you that if you have less than 150 on triglycerides, you're fine. But we know that that's a normal for people with metabolic disease.
Right.
People who are already eating a lot of processed foods that will never get triglycerides less than 100, unless they have some genetic modification that allows them to burn triglycerides very effectively. But if you are on a high carb diet, you are going to have triglycerides above 100. But their cutoff for healthy is 150 or less. So this right here, it's our cue. This plus the low HDL. Those are two our cues for us that these people have metabolic disease. They didn't measure insulin, of course. They don't have it on their map. So we are guessing a lot of these people were insulin resistant. They just didn't know it.
So yeah, let me repeat that for emphasis sake. So we're saying that, yep, just like Joseph Kraft said, those that have cardiovascular disease but don't have diabetes just probably have undiagnosed diabetes. And when you look at this study group, it supports exactly that. They've got relatively low LDLs for somebody with this problem, indicating that they're probably on high dose statins. Did they mention how many people, what portion of people were on statins?
I don't think I saw that.
Yeah, I don't remember seeing that either, but I'm assuming it's probably 99%. The bigger issue is the average triglyceride over HDL was what? Almost 3. So again, relatively low HDL, relatively high triglycerides, meaning, yep, they've got metabolic disease.
Let's do a quick math over here. Yeah, 3. You're better at math than I am, so good. And yeah, see here, even though the CRP is not elevated, you can miss a lot of cardiovascular inflammation if you only see CRP. And most of the lesions were on the LAD, the widowmaker. So no surprise on that too. Some details over here. So they were saying some of them received the metallic stents when the other stents got pulled off. So use of dual antiplatelet therapy, blood thinners, aspirin plus something else were more on the stent group. More than half of patients in both groups. Oh, so here's the thing you were looking for.
Yep.
More than half of patients in both groups were taking high intensity statins or moderate intensity statins plus ezetimibe.
So they didn't say what portion of them were taking statins only.
Just more than 50%. And there's an appendix that we don't have access to right now, unfortunately. Mean LDL cholesterol was 64 at last follow-up. So they decreased 88 in average to 64. Is that 20 points difference causing less heart attacks? I'm skeptical of that. No frequent angina, of course.
Especially with the continued lack of focus on metabolic disease. Did a drug-driven decrease from 88 to 64 on LDL cause fewer heart attack or result in fewer heart attacks in a group where not so much focus on metabolic disease?
And I'm surprised they're not in the Apo B trend and put Apo B over here.
That's a good point.
Well,
I'm not gonna take that bait.
I thought you will. We don't have enough time though. And well, see over here at 2 years, because that was the primary, the main time. So at 2 years, 0.4% of patients on the stent group had an event, and 3.4% of patients on the control group had an event. We discussed that. The risk of the composite patient-oriented outcome of all cause of death, all heart attacks, and revascularization was lower in the stent group. And this is what I wanted to show you. Numbers needed to treat. With the stent, 45.4 to prevent any event over 2 years, and 87.7 to prevent one cardiac death or reinfarctation over 2 years. So out of 100 people, you will have to put at least 45 stents to have one life saved. Is that an accurate description of what this is, what it says?
I think it is. And so, well, let me know when you're ready for me to do my 50,000 foot summary and recap.
Oh, well, we're almost there. Only 4 people out of 741 had a total of 5 preventive percutaneous coronary interventions related acute adverse effects. So few people had multiple events, so which is good. A stroke and bleeding events were not happening often. And this table over here basically just tells you the difference between event rates comparing the stent group versus the control group. And see here, that's for any cause. As the years go by, for the primary outcome, which is any type of event, there was just a difference between 2.6 to 3%. Death by any cause, it was bigger after 7 years. Death from cardiac causes, I want you to see that. So cardiac causes was slim. See? 0.1% difference between the stent group and the control group after 4 to 7 years. The most benefits were seen after 2 years of placing the stent. 0.6% difference. So 1 person versus 6.
So when the stent did help, in other words, it helped you get beyond the next couple of years, but really didn't change things.
Yep.
Wonder why.
That's interesting. And the heart attacks as well. At 2 years, only 9 people on the stent group have a heart attack, 13 on the control group. At 4 years was pretty much the same, 14 versus 15. At 7 years, 15 versus 19. So it's 1.2% after 7 years. The difference in favor of stents.
After 7 years, 1.2%
Mm-hmm.
in favor of getting a stent if you can get an IVUS or OCT, and they also find a vulnerable plaque, a specific vulnerable plaque that they can stent.
Oh, and go into the detail. If you see, if the heart attack was on the stent, on the place where they place the stent, it goes even lower, 0.3%. So not much of a difference between where they place the stent versus the versus the control group. So some of those heart attacks happen actually on another vessel where the stent wasn't placed.
Life gets complicated, doesn't it?
Can you see that? So the stent did not prevent the heart attack on the place where the stent was placed.
Right.
So the heart attack happened in another vessel. That's interesting. Then anyway, if you pull up the numbers and combine all of that, it will significantly favor the stent versus the control. This is not comparing versus low carb. Consider that too.
Well, that's exactly what I was getting ready to do. But let's take a look at the Kaplan-Meier's. That might convert a few people who are nodding their head with us so far and saying, "Yeah, you're right. I'd much rather treat this with not use a stent." Those are the Kaplan-Meier tables where they did use a stent in this case.
Yep.
So
more people died. The blue line is the people on the control group. More people were. Each change is 1 person who had an event. So more people had events compared to the ones on the stent group.
Before you move from that, you can see on this first one that the slope is not that different once you get beyond 2 years. Mm-hmm. It's that first 2 years that you talked about a minute ago where you saw that significant difference. So that stent may give you 2 years.
Yeah, and I see a stents like that, people who are very concerned about the risk and then they're very afraid and they're not exercising and they're afraid of having a heart attack during the exercise routine. Maybe a stent will give you some time to get on track and start developing that habit of exercising and eating better.
Let me ask you this question.
Sure.
So we have patients who come in that they've had a stent advised, and our advice is usually, okay, I'm not going to tell you whether to have a stent or not. That's a personal choice on your part. I know you've heard what we've said on the on the channel about the research. So if I'm one of those patients and I'm looking at this, and my doctor has said, well, I know you don't have angina, and no, we're not doing IVUS or OCT, but I think we ought to do a stent for you. And you don't have any occlusion, but I'm only going to, that doesn't matter. Let me rephrase that. I'm not going to do non-occluding stents. I'm only going to do a stent that I think is occluding. What would you do? Would you get a stent in that case?
I'll get a clearly test first.
Yeah.
A clearly CT angiogram.
In other words, you're not ready to pull the trigger on a stent yet either.
No, I would like to see if I have soft plaque. And even based on this evidence, I will say, well, the stent it's not necessarily putting me out of the risk of developing a heart attack on the same vessel where the stent is.
Right. Because doing it without the IVUS or the OCT, you might as well just be waving your hand and hoping, throwing some metal at somebody's arteries at random.
Yeah, and I want to make a significant case out of that. Target vessel related heart attack, that is where they place the stent. No difference between the stent and the control group. Very, percentage is a little bit higher on the first 2 years, but that's it.
What does that tell you?
That this is a metabolic disease. And an optimal medical therapy might have that optimal part to be questioned.
I didn't get that part.
Yeah.
Optimal medical therapy is probably the way to go. Is that what you're saying?
Well, on this research, I will say, is it optimal? This is no low-carb diet.
I know. I think we're both agreeing that their version of optimal medical therapy is not optimal. It's using statins and a low-fat diet, or recommending a low-fat diet, whether if that's even being followed or not. Hopefully, it's not.
And I'm open to be fact-checked. If the appendix actually says low-carb diet, I will give them that as well. But based on the baseline and what the definition of diabetes is and the risk is and the conclusions based on LDL, I don't think they're really concerned about insulin resistance.
Right.
Cut you off. You were saying something else, but I think you forgot already.
Well, I keep wanting to go to that 50,000-foot comment. Why don't you go ahead and cover some more stuff, and then we'll get to that.
Oh, yeah. We're about to close it off. We're almost done. So also, you are going to have a time. You might be running out on the airport right now trying to join to StreamYard.
And cursing under my breath if I'm not making it. We've always got next week.
Oh, yeah, of course. Okay, so preventive stent, according to this research, reduced the overall cause of death, heart attacks, and revascularization. Soft plaque, independently if the limiting flow cause heart attacks, which we agree with. The potential mechanisms is that obligate amount of neo-intima, new vessel that develops on the stent, can thicken the cap, reducing the risk of rupture. Maybe. So they're saying that when you place a stent, you're going to create a layer that will be similar to the calcification that you get naturally on your vessel when you're doing lifestyle changes. And some cap that may be protective, but I'm not sure.
So is that metal better than a calcified plaque?
That's what they're saying. That's what they're saying, because it will increase 210 micrometers compared to the 65 micrometers, which is what the regular thin cap measures. But, well, that's it. And Prevent has now shown that the study is saying it shows without a question that a stent will reduce your risk of heart attack 2 years after you have the stent. Probably on the first 2 years, it will have an impact. It's probable, yeah.
Possible.
Possible. And see here, patients in both groups were treated with optimal medical therapy and a stringent risk factor control with the achievement of low LDL concentrations. Success.
Lots of statins and ezetimibe and half.
Oh, yeah. Yeah. And I agree with this one. Previous natural history studies have shown that large plaque burden but especially high lipid content and thin fibrous cap are all associated with future cardiac events. I agree with that, especially the last part. Um, First new, oh, this is another, some caveats here that you want to know. There are like 8 of them. So the first one is new soft plaques might develop over time in each group and become clinically manifest. So they understand that you can build up more plaque than the one they found at the beginning. And the second part, they mentioned the differences between the bioabsorbable stents versus the metal stents. Well, I'm not going to go over that. Apparently, the metal stents were even better than the bioabsorbable, to their surprise. Some investigators suggested that the presence of soft plaque might be a better biomarker of a patient at higher risk than identifying a specific focal location at risk of plaque rupture. So I agree with that. They're saying, yeah, if you find soft plaque, that patient is a higher risk. And I think we agree with that. That's true. Up to 3/4, we believe it's a little bit, well, maybe it's the same number that you use, right, Dr. Burr? Up to 3/4, 75% of soft plaque might evolve into a more stable phenotype of plaque when treated with high intensity statin therapy. I'm going to rephrase that. Do you agree with that? Soft plaque will calcify with high statin therapy?
I do think that statin therapy has demonstrated calcification of plaque. I don't think that's a misquote of the literature, and I think that's something that statin haters hate to hear, but it's reality.
Yeah. Well,
statins have had an impact, and do tend to have an impact on calcification.
And the caveat is the high intensity will drive you into insulin resistance. That's why we say that the low dose will have better effects, actually.
Right.
But they might as better say high statin decreases LDL. That's what we believe. That's what they should say.
So I guess what you're saying is, do I agree with it? And you're keying on the term high intensity, and I'm not, and I'm ignoring the high intensity. I'm just saying statin therapy. Yeah, I agree with you. The high intensity is not. It will also drive calcification, just like a low dose statin. But as you pointed out, I don't use them. We don't use them. They create a whole bunch of extra risk that's not necessary.
Yep. And they're saying, well, based on this, stents are better than statins. I think there are other stuff that are better than both. Lifestyle is better than both.
Yeah.
First, the study was open label, introducing the risk of placebo effects and ascertainment bias, which is basically what you discussed at the beginning, putting higher risk on the plaque side or vice versa. They think the primary the results overall might not. Basically, I don't think the bias is that significant. I mean, they were basing the assumption also in that the people receiving the stent will have clear benefit. So anyone who wanted to change their treatment was open to do it. So if somebody was feeling insecure on just the medical treatment, was open to jump on the other side. But that didn't happen that often. I think only one person did that. So not significant problem on that side. And see here, we need to wrap it up, but see the number 4 here. Excellent risk factor control, especially of LDL risk, was why they did have less cases in both groups that they were expecting. So they're saying that's because of the LDL in both groups. Only 3 patients lost follow-up after 2 years, which is very low number, so that's good. See here, use of intracoronary imaging, IVUS and OCT, for soft plaque is not yet a global standard. So operators not accustomed to the use of this technology will need a training for that. And that's one of the big issues. And basically, there was no changes on the blood thinner treatment. I think that's kind of it. What I wanted to, I mean, there are a couple of other stuff, but I think this is one of the most important parts that we wanted to mention. In conclusion, the PREVENT trial of patients with non-flow limiting vulnerable plaques preventive stent
Um,
optimal medical treatment resulted in a lower incidence of major adverse cardiac events during the long-term follow-up. So victory for stents. Do you agree with that, Dr. Brewer?
Well, no, I don't. Uh, now, can I say my 50,000-foot interpretation?
Yeah, you're allowed to. Thank you, Dr. Brewer.
No more details
No more details. I think we saw enough, and people can go ahead and read this. And if there's something that we missed, go ahead and let us know in the comments. Is there something that we're misinterpreting? We will open to hear your comments because we'll learn a lot from those too.
We do.
Go ahead,
We
Dr.
do
Brewer.
learn a lot, and we make a lot of mistakes, just like everybody else. We're humans. The what the researchers basically used IVUS and OCT to say which are techniques that they acknowledge people don't do. You can't find that routinely in medical practice among your interventional cardiologists, the people that want to do stents. And they said if they used IVUS and OCT, they would find stents that they could really place, plaques that are vulnerable, and therefore they could give you a couple more years, hopefully, so you could clean up your metabolism. The people in this study did not. They went back to about the same experience after that 2 years. Now, is that true or not? My perspective is I'm still skeptical. Why? Couple of things. There have been how many studies looking at placement of stents? And there have just been no significant signals anywhere that those stents are actually working. When you look at this study, there's also some question about when they got improvement, how much of it was coming from that same vessel that they did the stenting in? And there's a significant question there. So am I saying for sure that no, IVUS and OCT driven stent placement is not a big opportunity? Well, I don't think it's a big one because I think it's been around long enough for the interventional cardiology community to adopt it, and they've shown that they're not. Number two, at this point, I would agree with David Diamond and others who talk about relative risk. In other words, I don't want to be a patient who's depending on an interventional cardiologist to decide to do an IVUS on me or an OCT in order to save me from plaque. There's way too much, and knowing that there's going to be a 1 in 78 chance that he does save my life, even if he does that, the number needed to treat.
45 for events, 85 for preventing deaths.
Saving life, yeah, 85. So I don't want to be one of those patients, and I don't want any of my patients to be dependent on that. When people do, as we've discussed, people do often come to us asking, what would we do? And we've told you what we say about that. One thing we didn't say is that we often have people that go ahead, they choose the suspenders in a belt. In other words, they go ahead and choose a procedure, plus they want to continue with us, and we support patients on that. Patients don't have to listen to us. We're not that patronizing where we think that you have to do what we say or we're not going to treat you. We will support you in achieving metabolic health. That is our goal.
Yeah, there are multiple things to consider, like if you're having chest pain, if you cannot exercise, if you have pressure from your relatives to get the stent because they're concerned and scared that you might die, and that's very, very much understandable. And I can tell you, even though I've seen the research and we see the numbers and we understand the lifestyle is more important, I'm not saying I might not get a stent if I get to be on that situation. But I think what we're doing is working actively on not being on that situation. That's the real prevention. Not be on the position that you need to think about getting a stent or not. And if you are already on that position, is working actively to decrease the risk of getting a new heart attack. And that can involve the stent That's a make involve a stent, but it's a 100% sure that it might require you to change your lifestyle. That's a given.
So whether you get a stent or not, focus on your metabolic health. And that's
Yep.
what we do.
Yeah. And I had a patient last week, Dr. Brewer, that told me I think he had a, like 80% occlusion on the LAD. He had a stent placed on February, and he was like, the doctor said that I needed a new one, and I said, well, I don't know if I want to get that, and he was fired as a patient because he declined.
Mm.
And it's like,
Yep.
we're
He
not
declined the second stent when the first one didn't work.
Yeah.
Yeah, I know who you're talking about.
So no, that's a patient that I had in Mexico. So
Oh, okay, because we've got one of those too.
yeah, I had one
I don't know if you saw it.
similar case.
Yeah.
And it's like, well, I mean, do you feel better after the stent? Yeah, it decreased my chest pain. So I'm
Oh,
cool
and this
with that.
one it didn't.
Yeah, exactly. And on my case, it did. And I was like, well, that's good. I mean, you're going to be able to exercise a little bit more. But they were concerned about those other vessels that they didn't stent at the beginning.
Yeah.
And they say, you will need a stent on this one sooner rather than later. And he was thinking about it, and he was fired from his cardiologist's office. I was like, well, at the end, it's your lifestyle. That's way more important.
Well, as we said from the beginning, we are all traveling right now. As if you're watching this, thank you for making it through this far. Hopefully, I'll be able to join us, and one of us will be able to answer a few questions. If not, we'll answer questions next week.
Hey, Dr. Brewer, are you ready? Jeannie?
Hi, Jesus. Dr. Brewer.
Good. We have some technologies and delays for sure. We're all
doing our
running
best.
around. I'm surprised Dr. Brewer's internet is the worst of all three of us.
He's at the airport.
Why are you so blurry? You're on mute, Dr. Brewer. Oh, he might not be able to talk just yet.
Okay.
Yeah.
I just literally sat down in a grill here in the Dallas airport. And my phone, I'm using
I'm
my
at the hotel.
phone as the
I'm at the
Wi-Fi.
hotel.
Oh, it's a nice hotel.
Yeah.
Well, I'm on the airport and I'm here early,
There's our
so
helpful staff.
I still have 2 hours to wait. Hey. So this is going to be a wonderful time.
very
If you missed it, if you missed being on Dallas, don't worry. We'll have more events coming up. So I'll be putting those on the screen for you. Let's go ahead and start so we don't go too over the top on time. I
Okay.
just want to give a shout out to Jason Todd. He just became a member from PrevMed Health channel. Remember, you can just hit the click on the join button next to the subscribe button, share, like, even dislike or share with your enemies if you don't like this content. Any of that thing, any of those options help. We have some questions to address, Dr. Brewer, and some comments. I'm going to go through the comments real quick and then the questions. So Richard Mills, hello. Thank you for being a YouTube member, just as Keith Lawson and Burgers Nichols. Richard, don't be sorry about missing Dallas. Don't worry. We all have work commitments. It just so happens that this is our job, so we're blessed with that. Joey T, what can cause a stabilized plaque to change and become soft and vulnerable to rupture? Do you want to tackle that, either one of you?
Go ahead, Jeannie. Uh-oh, can't hear you.
Yeah, we can't hear you for some reason, Jeannie.
Can you hear me now?
Yeah.
Yes, we can
Okay.
hear you now.
Okay, I'm trying to go to a quieter area. Once we get that plaque calcified, then it becomes stable, and the risk of it dislodging or becoming soft plaque isn't necessarily there unless you would go back to what you were doing before you stabilize your plaque.
The same stuff that created the plaque in the first place.
Right.
Yeah.
Lifestyle.
If I may go to,
Yeah,
it's lifestyle. Poor lifestyle, eating processed foods, drinking all the sodas, getting all those sugary drinks, all that stuff is gonna build plaque. Yeah, I was gonna go into Bonnie Hall, but we can leave that for another moment.
And those are the members. I think probably they thought that we were not going to be able to answer questions, and surprise, we're here. So I'm going to go with JMK. This is a really important message from, well, an important comment from JMK. If coronary stents are an option to prevent MACE, major adverse cardiovascular events, heart attacks, strokes, cardiac deaths, wouldn't it make sense to check serial CT angiograms, preferably clearly, which is the AI-driven that can detect soft plaque, for people with who already had coronary artery disease?